efficiency in DNA repair capacity, leading to cell cycle apoptosis. So these were significantly associated with hematotoxicity. So in other words, they are predictive of what is happening. So that strengthen the usefulness of such assay for risk prediction, as well as the functional study, how they are related to each other. All right, next slide. So for all the study we have been doing, so as well as the new emphasis is that we need to go from population to personalized medicine, as well as for risk assessment. For example, it will be much better if we can provide information to say an individual with a risk of more than 50% chance of lung cancer, the personalized risk assessment, rather than saying that, well, you're exposed, for 100,000 exposed people, there are 50 cases of lung cancer. Right? So this is what is currently done. But we need to go to this level. So the challenge assay is along the way of achieving this goal, right? Yeah. So we need to identify, oh, Nick, go back. Yeah. Thank you. Yeah, we need to identify the process to identify individual risk. For example, in patient also, we have identified that the patient have significant reduction in basic cell repair capacity, as well as the cancer cell in other studies identified their basic cell repair and homologous repair deficiency in cancer cell, particularly those with BRCA gene mutation. So you can see immediately there are differences between the normal cell and cancer cell. So you want to avoid using drugs that require DNA basic repair, because both the normal cell and the cancer cannot repair, so you're affecting normal cell. But you will need to use medication that the cancer cannot repair damage, like homologous repair deficiency. So normal cell can repair well. Normal cell repair well, cancer cell cannot. So if you use the drug that the cancer cell cannot repair damage, it will be more effective. Or nowadays, there's a new way called synthetic lethality that make use of the density, some defect in cancer cells, making them to be less sensitive to damage. So it enhances the sensitivity to therapy. So hand in hand, these two will be useful in improving risk assessment and medication. Is it coming for me? I'm almost done. I have 2 more slides. Next slide. Right. So I have summarized the challenge assay using bone marrow, using chromosomal aberration or COMET. But there are other approaches that can provide similar information. This is a summary of them. For example, one can go back. Sorry, one can use the LC-MS, liquid chromatography mass spectrometry, to look at DNA adduct. So presence and removal of DNA adduct is indication of repair, but they don't use challenge. Or you can use gene based on quantitative PCR, look at RNA expression, before and after exposure, but there's no challenge. You can use FISH for chromosome analysis, but this is very complicated and expensive. You can use gamma-2AX with challenge to measure DNA double-strand break, but the sensitivity need to be validated. And you can use the challenge chromosome, challenge micronuclei, and challenge COMET assay I have mentioned to you. Right? So these are some of the new assays that can be used, and you need to be thinking about how to design study and how to use the data for risk assessment. Next slide, please. All right, future opportunity. So based on what I presented to you, My emphasis is to use relevant and functional biomarker to provide precise risk assessment, combine biomarker effect with clinical observation to enhance risk assessment, conduct prospective study, long-term study to validate effect, improve disease prevention, molecular intervention, gene therapy. So that's the end of my slides. I hope I have some time to answer your questions.
Wonderful. Thank you very much, Dr. Al, for this outstanding presentation. Now the presentation, it's open for discussion. If you have any question for Dr. Al, you can raise your hand or you can write it in the chat. Don't feel shy. Unmute yourself and you can ask.
Any question, fine. It is good for discussion.
Maybe I start.
Please go ahead, Dr.
Sure.
Yeah, you know, in terms of expenses and practical, يعني how practical this challenge assays for repair, يعني can this be used for large scale population or
Yeah.
it is
Well, you do population study all the time, so it's not much more than just a regular population study using lymphocyte. But the one key step is to add a challenge agent. So if you have access to X-ray machine, at 24 hours after the culture, you irradiate the cell, and 20 minutes later do the COMET assay. So or 24 hours do a chromosome. But if you don't have the X-ray machine, you can use set of UV light, the germicidal lamp, to do. So one extra step, but we will provide the functional data and quantitative data for individual risk assessment.
Yeah.
So it's not much more than what you normally do. With the COMET assay, very quick, then you can get the work done quickly.
But these studies is a population study, and you have the results from a large number of people. But on individual basis, is it enough to do the test for one person and predict what will be happening? Or
well, it's also it need to do a population study to minimize variation in study, you know, and it's not a clinical diagnostic test. You can do just one person, so you need to actually establish your background, your baseline, your expertise, so that you do enough that you'll be able to consistently do the analysis. And whatever collected data from your population study is used individually. You don't do individual, but you do a population of individual data. Yeah.
Okay.
So yeah.
Yeah, Dr. Al, we have a question on the chat. It said, how can you quantify the risk? Do you need to involve many functional markers?
So the quantitation is based on equation I showed to you, and of course there are many other factors that affect risk, but DNA repair is the key factor because it controls how cell repair damage. We all know when the damage is not repaired well, they have very serious consequences. So the measurement of DNA repair capacity is a major step towards individual risk assessment. And of course, as I mentioned, that you need to work with clinician, with other to monitor, because if the person smoke, there will be very good reason to tell the person to quit smoking to reduce the risk. And also if they have been exposed to a high dose of chemical, reduce the exposure. So these are the steps that can be done right away with your data. So let's say in the population of workers, maybe 10 of them have very, very abnormal repair capacity. So you need to focus on those 10 rather than the entire workforce. Yeah, that will be useful.
Wonderful. We have another comment on the chat from Dr. Ahmed Ismail. Thank you very much for this wonderful lecture. We appreciate all the effort put together to give this comprehensive overview. Thank you, Dr. Al. So I have a question for you. There are many people, like for example, Dr. Ken Alden. They believe that the epigenetic event may play a major role more than genotoxic effect, especially regarding the effect of environmental pollutants. What do you feel about that?
Yeah, well, yeah, the epigenetic factor has been looked at. It's an important factor. For example, induction of microRNA expression or methylation of DNA. Those are some of the key factors. Some of the factors that involve with it, but key is the function that can be influenced by genetic factor, epigenetic factor that we can measure. So the DNA repair capacity is a holistic measurement of repair capacity from genetic and environmental factor or epigenetic factor. So.
Wonderful. We have question in the chat. They ask, can you share some of your publications on the individual risk assessment for carcinogens?
Yes, thank you. Yeah, on my slide I have I listed two of my review paper recently. I've already sent the newest paper to Professor Wakita, and she can send to you. And feel free to use the data, use information, and I shall be glad to provide more consultation on your work. Because risk assessment is very important, very essential.
Wonderful. Thank you very much. Any more questions or comments?
I hope everybody write his name and affiliation and email. And if anybody requests, this publication, you write on the chat so that we can send it to them.
Sure.
How can I know?
We have another question on the chat from Dr. Ola. It said, how we choose the specific microRNA for the case of the study? How you decide which microRNA test to use?
Yeah, it based on a lot of experience on what gene are you looking at and how certain microRNA are affecting certain gene. So there are thousands of microRNA. You can measure everything. So depending on what gene you're looking at, for example, DNA repair, that you're looking at what microRNA affect DNA repair. You look at the changes.
Wonderful. Thank you very much. Any more questions or comments for Dr. Al? I hear none. Really, please join me. Give big hand for Dr. Al. Thank you very much for this outstanding presentation.
Thank you all.
Thank you very much.
Thank you.
And we'll be discussing maybe